Modern gender-affirming surgery techniques were always trying to preserve the nerves. I remember the first time watching a bottom surgery and thinking, there goes sexual function, but that's not the case at all. What I favor is my name is Dr. Sidhbh Gallagher. I am a plastic and reconstructive surgeon.
And people say there's not enough evidence. There's much more evidence for this than lots of other things I know that we're doing.
Transgender folks tend to be the best educated patients I have because they've been researching this for 10 years plus, so they know exactly what they're signing up for. One particular patient who really affected me, actually, he was a firefighter and a very decorated firefighter. Coming out and living as her true self required way more bravery than anything she'd ever done, like running into a burning building.
I can just picture the joy, the open, the warmth, that reveal.
That's really the best day. We'll remove the dressings, we'll get rid of the binder, and that's when they'll see their chest. This is like one thing they've looked forward to all their lives, and it's such a big deal. It's such a happy, emotional time.
But I'm interested in scar management.
You can spend a lot of money buying different types of lotions and creams, and unfortunately there's very few that have good data behind them. So the main thing that has science behind it is
Dr. Sidhbh Gallagher, so lovely to have you here. Tell everybody who you are and whatever you're doing talking to me on this lovely afternoon.
Absolutely. Well, thank you so much for having me. So my name is Dr. Sidhbh Gallagher. I am a plastic and reconstructive surgeon here in Miami, Florida. But as you can probably tell from my accent, I'm not from here. Originally born and raised in Ireland and educated in Dublin. But I came over here almost 20 years ago now. I trained as a general surgeon, then trained as a plastic surgeon, and then finally found my true calling in gender-affirming care.
So was it a patient that came in? Was there a single moment? How did it actually start?
One particular patient who really affected me, actually, I can think of, he was a firefighter and a very decorated firefighter. And he expressed to me that coming out and living as her true self, so she transitioned from male to female, was way more brave, required way more bravery than ever anything she'd ever done, like running into a burning building. So she expressed that, very eloquently to me that, she's like, risking my life. I mean, that's nothing, because, I was a hero in that situation, but coming out and living as my authentic self, that has been extremely difficult. And on some level, I think we can all relate to that, right? Because there's always something we may be kind of hiding in our personalities that we're not comfortable with. So, I mean, I could relate to these patients on that level, but I mean, I obviously couldn't, fathom how difficult it was living as a transgender woman 11 years ago in the Midwest. And I just thought like, whoa, that like the strength of character it takes to do that, you got to admire it, so, that was kind of my early experiences with the community. And then, it, like I said, just being in that work environment where it's such a happy time, their dreams are being fulfilled. And, the amount of gratitude as like patients express, as is extremely humbling.
Yeah, absolutely. So what kind of operations do you do? Do you do the whole range, or what's your favorite?
I would say over the past few years, I've kind of specialized in a few areas, and like I said, thankfully now there's a lot of innovation, and techniques are improving. And one of the things that really draws me into plastic surgery is you can always get a little bit better, right? The thing I didn't love about general surgery is the gallbladder's either in or it's out, right? Whereas with so much of plastic surgery, the aesthetic result can continue to improve, throughout your career. So I would say most bottom surgeries, I do a little bit more for trans feminine bottom surgery. So I do a good range of different procedures there. I do a lot of masculinizing top surgeries. So I'd say that's kind of my signature procedure. And it's something I'm very proud of. I've published over the years, and we've continued to improve the technique, and particularly in all sorts of body types, right? So one of the big myths that used to bother me a lot when I got into practice practice at first was that BMI cutoffs. You need to be a BMI below 25, which is kind of ridiculous. So I spent a lot of the earlier part of my career kind of trying to dispel these myths with data and publishing on it, that we can, safely deliver. Like BMI, it's not sometimes the best measure, and we have to look at each patient individually, because we know, for example, in transmasculine folks, they're much more at risk of obesity, and then to deny them care based on an arbitrary number, it is obviously not a great thing. So the early part of my career was kind of focused on that, and then it's very interesting with the new weight loss drugs, the GLP drugs. I've seen a kind of change in my career. So, when people lose massive amounts of weight, which people are now succeeding, it's really, the first effective drug, had. Before it was just surgical options, really, so people are losing a lot of weight. And so along with this massive weight loss, they're requiring skin removal surgeries. It's not necessarily just an aesthetic thing. It can be a very functional thing, as you know. So how do we approach these patients from an affirming perspective? So we're not doing, let's say, on a transmasculine individual, we're not doing a traditional tummy tuck where we're trying to create an hourglass. How can we masculinize that? So I really enjoyed doing those surgeries in the past few years. I've published on it, and just trying to, at the intersection of massive weight loss, but make a gender affirming at the same time. So I've really enjoyed that. And it's kind of, one of the things, there's not much publications on it. We need to get more publications out there. But traditionally, when we talk about gender affirming surgery, people think of the genitals, right? Or the breasts. But one of the things I am certainly understanding, in my patient population, it can be a little bit more than that. And sometimes the body contouring aspect can be nearly as important, or even more important, especially if the patient is living in a kind of dangerous environment where they need to pass, so that those type of surgeries have become really interesting to me. And another thing, which again, it sounds kind of out there, it sounds a little bit wacky, but in plastic surgery, we know how to handle the skin, we know how to handle the fat, we know how to tighten the muscles, and the next horizon is the bones. And that is really interesting, especially for trans feminine patients. So what I mean by that is rib remodeling, for example. So it sounds extreme, and patients or the public in general, tend to think it's a little bit out there. But that's something that I've incorporated into my practice. One, because it's extremely safe. We're getting good data on it. It's minimally invasive. And basically what we do is, for example, in a trans feminine patient, they tend to have a very barrel chest. So it's hard to get curves. It doesn't matter, how much dieting or exercise they do, the ribs are always going to be in the way. So what we do is we take the lower 3 floating ribs, and we just do an infracture just through a needle stick. And we put them in a corset for 3 months, and now they have a hip to waist ratio. So they finally have curves, which again, can bring so much joy and relief, to this population. There's other procedures I don't do yet, modifying the pelvis, modifying actually the shoulders, narrowing the shoulders. So that's kind of the next horizon we're seeing from a technical point of view. I'm a chicken when it comes to surgery. I do not like complications, but I kind of sat on the sidelines and watched a little bit what they were doing with rib remodeling in South America. It all originated from South America, and looked at the safety data, and it's very good. And so for the past year and a half, I've been offering that in my practice, and that's been fantastic.
Sorry to interrupt. Thank you so much for being here. Thank you for listening. Thank you for watching this video. I notice that some of you don't actually subscribe, and it would really help me if you did subscribe, and it will also make sure that you can get my next video if you want to. So just click the button. That's amazing. I hadn't heard of that. That's amazing.
Yeah.
And also, you're doing it loudly and proudly, because I think I was saying the other day that I think there are doctors providing this care, but maybe they're just doing it quietly at the moment because it's a risky thing to be public about. I'm sure I went through quite a few years of regulatory, I don't know what the word is, regulatory investigation to see whether my work was okay, and it was. And you've had your fair share in the newspapers, I noticed recently, and that's what happens if you put your head above the parapet, you get shot. But well done you for not taking it down.
Yeah, you got to be on the right side of history, because like even just from a scientific point of view, and that's what we're seeing in our medical societies, like thank goodness the vast majority of doctors are like, we don't care about the politics. There's no room for that here, or your personal emotions. Let's just look at the data and continue. We're science based, science driven. And so thankfully the whelming majority of doctors, that's what they're going to look at first, and accordingly treat their patients or make their decisions or make their policies or their society recommendations, thankfully.
And people say there's not enough evidence, and it's like there's oodles of evidence. There's much more evidence for this than lots of other things I know that we're doing. I had an email from Medscape the other day with this bizarre drug for pediatric migraine, and I'm like, I've never heard of this drug. I looked up the data, and I'm like, there's hardly any, and yet it's being promoted to me in email marketing, kind of, use this in pediatric migraine. And I'm like, how are they getting away with that? So, we have lots of beautiful data to show that this care is successful. It's just what you want to look at, I guess.
And even, just from a philosophical point of view, if a patient, let's say a cisgender woman comes to me for a breast augmentation and subsequently regrets it, which happens a lot, it's depending on which elective surgical procedure you look at, the regret rates are kind of high, but nobody bats an eyelid. There's no shock and horror, whereas we do have great data looking at, for example, if a transmasculine guy comes to me for top surgery, the rates of regret are 1% or less. But it's kind of, again, this whole notion of bodily autonomy. Well, if a girl comes to me and then subsequently regrets getting a breast augmentation, that's not news. It's yeah, does she change her mind? That's okay. People can change their mind. So it's very also a double standard.
And it's also about expectations, isn't it, as well? The young girl that wanted breast augmentation, what did she think it was going to do for her life? And did it achieve that for her life? But we don't know, but actually with transgender people, they have a very, very clear idea of what the surgery will do for them. You can picture it beautifully, what it will do for them, whether it's playing football topless or going swimming in swimming trunks instead of having to cover up, they know very, very well what it's going to achieve for them. So it's no wonder that the regret rate is so low.
It's hard to access this care. So I'm sure it's been your experience, and transgender folks tend to be the best educated patients I have, because they've been researching this for 10 years plus, or even longer, so they know exactly what they're signing up for. And, it's like, sometimes occasionally when I go to the hospital for a more complex case, I might work with an anesthesiologist who's not as familiar with my patients, and they'll comment on that. They're like, this patient is really well educated. Yes, it's taken them a long time to get here.
There's nothing like 10 years of time to give you all that knowledge and research and find out where did you go, how did you do that, what's it going to be. Amazing. And the other thing I wanted to ask you about, because obviously the public hear it a lot, is that surgery is going to interfere with sexual function, and it's not what I hear. I hear that I used to do psychosexual medicine a lot, and I've always used to say to my patients that your brain is your biggest sexual organ, and if things are not going right in your brain, it's not going to work downstairs. But then get rid of those dangly genitals that you don't want, and make something neat and beautiful, and it's going to allow you to open up, as they say. I mean, is that your experience? What do you find?
That's exactly my line. I use the same line about the brain, because we know this when it comes to sexual function, so with modern gender affirming surgery techniques, we're always trying to preserve the nerves, that's huge. And so that's, the very basics, right? So And thankfully, in 11 years, I've never had a situation where the nerves are damaged, So in general, we say to patients with bottom surgery, if you're able to orgasm before, you're more than likely going to be able to orgasm after. Now, it could be quite a while. So because, the swelling and bruising and just the general ickiness that people, feel around the time of surgery, they don't feel sexual, So I tell people it's not unusual, for example, for trans feminine bottom surgeries, that it could be 3 months, before they have an orgasm again. So the type of bottom surgery I do most often would be vaginoplasty, or variations on that, depending on the patient's needs. And what I mean by variations is sometimes patients will just have an orchiectomy. Sometimes patients will feminize the external genitalia without making the canal, because they don't have any need for it. They don't want the risk. They don't want to have to dilate. And then, of course, there's full vaginoplasty. So it's really important that patients are aware of it's not one size fits all. You know what I mean? That or no surgery is perfectly valid as well. So but with regards that the trans feminine bottom surgery, it tends to be quite an elegant procedure in a way, because we're preserving the nerves to the head of the penis, basically, which will become the clitoris. So we have sensation there. And also we basically end up having a G-spot, basically, because the prostate ends up about 2 inches in on the anterior surface of the new vagina. So some patients can get erogenous stimulation from that too. And no matter the type of genital surgery I do, trans folks, cis folks, I've started doing a lot of actually clitoris reductions, because there's a lot of people in the United States, a lot of women, I should say, menopause and postmenopause, who will start testosterone therapy. And it's an area that's kind of, not there's a lot of charlatans in it, honestly, who are given large doses. And so they'll get bottom growth like transmasculine folks do, but it gives them dysphoria because they're cisgender women. So, thankfully, because I'm familiar with working with the transgender population, I know that anatomy, and we can help reduce that clitoris. But again, in all of these different populations, we're seeing that if the anatomy fits better, sexual function is better. So and sexual satisfaction rates are higher. I'm saying this anecdotally. I need to study it. I need to document it, but but the plenty of other people have done it, and that is the case. That from a sexual point of view, it can be surprisingly good. I remember the first time watching a bottom surgery naively when I was a student and saying, "Oh, whoa!" Because you're basically completely disassembling the penis, for example, and thinking, "Oh, what a sacrifice, there goes sexual function." But thankfully, that's not the case
No,
at all.
no.
What I favor is using the peritoneum. So, unless you're in the medical field, you've kind of never heard of the peritoneum. So basically, very simply, what that is, on the outside of your body, you have your skin, let's say on your torso, but on the inside, there's kind of like a skin. It's a shiny layer called the peritoneum that lines the inside of your belly. And so one of the techniques we can use is a peritoneal vaginoplasty, where a very skilled urologist usually can lift that tissue up and flop it down, and we can connect it to the outside, and that's your new vagina, your peritoneum. So there are different ways, to line that new vagina. You don't exclusively need penile skin, and we can definitely rise to the challenge as plastic surgeons. That would be my philosophy. You're not going to be able to use your traditional penile inversion technique. And in the folks I've done surgery on with a micropenis, they've done fine. So but yeah, you just need to be able to have access to doing which, thankfully, it's one of these great things. Every urologist who knows how to take a prostate out knows how to do a peritoneal flap. It's the same anatomy, the same skill set, pretty much.
So you go in through the vaginal opening to get the skin down, not through
Exactly.
the abdomen. Yeah.
So what they use, actually, it's a really cool surgery. So basically they use a robot. So it's kind of wild. So they put 3 little ports in the belly. and they scrub out and go to a console. So they're playing computer games over the other side of the room, which I still have a hard time getting my head around. So the urologist is not scrubbed in. And then meantime, I'm down between the legs working away on the outside, and he's working away on the inside, and then we meet. So then I pass it later, and then he sews the peritoneal flap over it, and that's peritoneal vaginoplasty. So unfortunately, there was a hope that it would be, we could avoid the need for dilation and things like that, and it was going to act more like a, like quote unquote natural vagina, but you still need to dilate for sure. And there's not too much more advantages, but for that patient you spoke about earlier who has been through puberty blockers, this is a great procedure for them.
Yeah, amazing. That's really cool. That's so cool. Love learning. It's just fascinating, isn't it? It's just amazing. And then the other thing I was going to ask is because I know puberty blockers are very hard to get hold of now, but one of the reasons that people use for not giving puberty blockers is, oh well, you won't get enough penile development, so growth of the penis, in case you wanted to use that later to make a new vagina. And I'm like, well, hang on a minute, but your penis isn't going to grow for your penis to grow big enough to make a usable vagina. That's quite a lot of puberty to have to go through, and you can't just choose the penis to grow, because everything else is going to happen too, the voice and the skeleton and the hair and everything. So what's your take on that, having to use penile skin versus bowel, or are there other ways? I don't know.
There definitely are. So what I would say is, if somebody, and it's very interesting because I have never had a patient come to me for bottom surgery who has had access to puberty blockers. So it's incredibly rare, first of all, that people have been able to access this. Like, not a single patient over 11 years have I had who has been on puberty blockers. But having said that, I've had plenty of patients who, for whatever reason, sometimes even intersex conditions, or we're not fully sure why, but have a micropenis, or like not much development there. And so you just have to, that's one of the great things about, plastic surgery. You got to innovate, right? Like, because people are not one size fits all, you're right, so it's like, you don't know what's going to, come through your door and what specific needs they have. But that's why we're plastic surgeons, right? So we innovate, and there are alternatives for sure. So it's very true that if somebody has been blocked at puberty or has a micropenis, we're not going to be able to do our standard penile inversion vaginoplasty, but we have alternatives. So like you mentioned, there isn't testing. I personally haven't done that because I feel like it's a little bit invasive, and some of the reported outcomes on that, there can be some complications. However, there are surgeons who do it and do it very well.
And I just want to talk to you about like the effects, like scars, and you talked about people who are overweight, and the fact that their body shapes are going to be different and may change, because there's nothing like a bit of body confidence to help you with your weight loss. So I always felt it was so cruel to stop these people having surgery because of their weight. I mean, so cruel. When if you dig deep at the reasons why people restrict or overeat for that emotion, for whatever emotional reasons, and then to use it as a barrier, it's just inconsiderably cruel. But I'm interested in scar management and things like that. I'm sure people ask you about that, and I'd love to know what your thoughts are.
Yeah, especially with top surgery, let's say for transmasculine folks. I always say, the chest, unfortunately, it's one of the worst places we can put a scar, so we think that's because there's probably a lot of movement in the shoulder girdle. We know a lot of movement across the scar is usually a bad thing. So if you're going to get a hypertrophic raised scar, that's usually the part of the body you're going to get it on. So from a technical point of view, we want to, as much as possible, put that scar in a natural fold, so usually we'll try and put it underneath the pec muscles, so at least if we have a visible scar there, in the long run, it's in a natural fold and it doesn't kind of catch the eye as much as it might elsewhere. So that would be kind of the first principles, like the technique at surgery. all plastic surgeons, we all do a meticulous closure. You know, I would never claim that there's something kind of special I do, because we're kind of pretty much all doing the same thing. It doesn't matter what type of plastic surgery, you got to minimize the scar. So we're all going to do a meticulous closure. And then after that, it's, you know, taking care of the scar itself. It's interesting. There are so many products out there that just have no science behind them, unfortunately. So you can spend a lot of money, you know, buying different types of lotions and creams. And unfortunately, there's very few that have good data behind them. So I'm one of these people, I'm a bit of a nihilist. If it doesn't have science behind it, I'm like, don't waste your money and time. So the main thing that has science behind it is silicone. And so just like the element silicone, there's something about it which we don't fully understand, but having silicone itself in contact with a scar seems to help it. There's some data that it's maybe about keeping a moisture barrier over the scar. We're not quite sure, but silicone, nobody's got the patent on silicone. So when you're looking at different products, the only difference between the different products is, first of all, are you going to use a gel or are you going to use a tape? Most patients would prefer a tape because it's a lot less messy. And so then the only difference between the different tapes is the adhesive. And so how good the adhesive is it going to stay on all day, all night, and whether or not it's good for sensitive skin. So there's a few products, you know, I recommend to our patients, but they're fairly decent price wise. But a silicone tape, I would say, is the most essential thing. And you try to have it in contact with that scar from about 2 weeks after surgery till as long as it takes, you know. So it could be 3 months. I tell patients to reevaluate 3 months. How do we like the scar? If we don't like it, okay, we're going to keep using it. That 3 months, or even earlier sometimes, is an interesting time to look at the scar, because that's when things are remodeling. And we're beginning to see, are we getting a raised scar? Because it may be time for intervention. We used to say wait about 3 months, and then now there's a trend towards early intervention, doing something sooner. So what I mean by that is usually some sort of injection. So the different classes, you know, good old steroids, they can be useful, or there's some other kind of chemotherapeutic agents that are used as well. And so typically they'll be repeatedly injected into the scar, either under the surgeon supervision or the dermatologist supervision, usually to try and get better scarring. There's a role for lasers as well. A lot of times, you know, that's not covered by insurance, you know, here in America. So a lot of people may not have access to that, but they can take the pigment out of the scar earlier. And then later on, let's say after a year, you could actually consider tattooing, you know. So there's good results, whether it's just, you know, hiding the scar with a chest piece, that can be really effective, or kind of more medical tattooing, putting pigments into the scar itself. Sometimes there's a role for a scar revision. It depends. You got to look at the scar. If the whole scar is kind of raised and looking not great, you know, it's probably doesn't make sense to revise it, because we're probably going to go back to square one and may even work. Yeah, potentially putting more tension on it. So, but if there's patchy areas at a year, we may consider taking those out and revising those.
That's really encouraging because, you know, like you say, nobody wants a scar, but if you have surgery, you've got to do some cuts. So there's going to be a bit of scarring. So, but that's, so, and again, you know, we need that data, don't we? We need the research. We need to understand why and what's going to help.
No, it's very true. And it's something I talk to colleagues about a lot. It's, you know, traditionally in Western medicine, we're way behind, you know, yeah, and even in the United States, in some aspects, we're behind parts of Europe, because you know, there was always a lot of suspicion around the community, you know, a lot of setbacks from that point of view, poor understanding, and even, you know, the surgical standards, which one of the things I love about my field is anybody walking down the street can tell whether you do good work or not. You know, it doesn't take an expert to look at it before and after and figure out whether or not it's good work. And I mean, honestly, the standard of work, you know, hasn't been great. It's rapidly getting better, you know, in the United States, but compared to other aspects of plastic and reconstructive surgery, traditionally the standard's not been great. And that's one of the reasons I fell in love with this type of work 11 years ago, because first of all, I was in the Midwest in America where there was literally nobody to go to. There was no competition, you weren't, there was no alternative. And, when you looked at even some of the aesthetic results, so let's say top surgery, they just weren't great, but like I said, thankfully, as this work has become a lot more accepted and mainstream, and despite what you see in the media and what they'd have you believe, the trend is moving definitely in the right direction. Like all the major medical organizations in the States, for the most part, understand this work and believe it. And one thing that really encourages me is I get a lot of interested medical students, people who on their own initiative and their own dime sometimes will travel down to shadow me to become familiar working with the community because they're interested in doing this work in the future. And the next generation definitely get it, So from that point of view, I think the future is very bright.
That's amazing. I mean, I think we're falling so far behind in the United Kingdom, just in terms of standards of education, standards of training placements, none, no standards of education, nothing in the curricula to even make a start, no standards of education, no training placements, no practicing clinics. It's like, oh my goodness, where are we going to train anybody? And then no kind of clinical guidelines to follow in the UK. And I'm like, we're supposed to be the United Amazing Great Britain Kingdom kind of thing. And I'm like, oh my goodness. So I'm really pleased to hear that you've got you're that further ahead, because like you say, the headlines would want us to believe differently. But that's a tiny proportion of people shouting very, very loudly. And I don't think it's the norm.
Yeah, absolutely. I agree. And it's in some ways, I'm an eternal optimist. Sometimes, maybe not the most realistic person, but what I will say is I am in Florida, which is a very conservative state, and it's kind of a microcosm of America, but I would say we're about 4 years ahead, maybe because we, have some very conservative leadership who have been here at a state level for longer than what's been going on at a federal level. So I kind of feel like we can see what's happened in Florida and maybe predict what's going to happen on a larger scale in America. And it's good news, because initially there was a flurry of legislation, which for the most part has been defeated. And very interesting thing is this year they didn't try anything. Last year they didn't try anything. So it's almost like that small group of people that are trying to, prevent access to care, things like that, they kind of gave up. I hope I'm right about this, but 2022 was a very bad year for us in Florida. But since it's kind of been peaceful and the damage done in 2022 for the most part has been defeated, so I hope that bodes well, because as you and I know, and I mean, the statistics are extremely clear, the average person on the street doesn't have the same degree of transphobia that may be, reflected in current leadership,
One of the things that I always say about myself and my journey is that, there is discrimination. And I feel that I have faced discrimination by association with the transgender community. And I also feel personally, I don't want to put words into your mouth, but I'm interested in your experience, is that because I am just a GP and I'm just a woman, and I'm just Helen, that I faced more discrimination than if I'd been a male, suited, dressed in a suit, professor type person in medicine. And we do know that there are, sex-based discrimination in medicine. I just wondered, because obviously you're female, you're just Sidhbh, and I just wondered whether you felt that you had faced any discrimination that way.
Yeah, like, for sure. So, what I would say is definitely when I worked in an institution, it was more difficult, So when I had a big team of male colleagues, and definitely, competing for resources, because I had my gender affirming surgery clinic, but I kind of felt like we were the redheaded stepchild kind of thing. Like, we were always the last to get the resources and that sort of thing. And I began to feel it in that environment, especially when I was competing for resources with male colleagues. And so that inspired, I'm like, well, if I don't like it, I need to just go out on my own and, let the patients vote with their feet, right? So, be in a situation where I have my own practice, we can run things well. If I don't like the flow of how patients are coming through or how efficient it is, I set up my own practice and, like a lot of these things and the type of discrimination, you've probably experienced at that level, you can take care of, by having your own practice. So that kind of inspired that. And I mean, I think it's true. I mean, one thing I really admire about you is that you're gifted, you're an extremely good speaker, right? And one of the things I love about it is that, you're willing to be an activist and to bravely stand. And when you speak with a lot of poise and a lot of authority. Whereas I don't think that's necessarily my strong point. At the end of the day, I'm a surgeon, and I don't do well in debates and that sort of thing, because it's just not my strong suit. So, I don't know if it really matters. When you speak, I feel like you bring a lot of gravitas to the conversation, and I would like to think that the public will give you as much credence as a guy in a suit. I don't know. Maybe I've just been optimistic here, but and definitely I do have some colleagues, who thankfully there's not many of them, but they are the guys in the suits, and I think sometimes they do have to. They're probably the best person to put into that situation, to speak with authority, unfortunately, depending on who they're meeting with, politicians or whatever else. But yeah, like, yeah, other than that, I would say that, like, one of the great things about America is, it's a capitalist society, for better or for worse, but, you can go into your, own solo practice and let the patients vote with their feet, so it's fair from that point of view,
Yeah,
you know.
definitely. And I think our NHS is such a monopoly that if you're outside the NHS doing something different, doing even if you're doing what, because when I started, there was nothing in the UK. I was looked everywhere. I'm like, where's the book? Where's the rule book for this? I need to know what to do. And I'm like, it's not there. And I'm like, what do you mean it's not there? There's a rule book for everything in medicine, and it wasn't there. So I was like, oh well, I'm gonna have to go out and find one somewhere else. So I found them in America. But then it was criticized that I used that because, but I'm like, hang on a minute, you didn't give me one to use in my own country, so I had to go and get one from somewhere else, and now you're criticizing. It's like, go and make the one for my country.
Yeah, that's the one.
But
Yeah.
yeah, but yeah, so it's difficult. The NHS has a huge monopoly here, and if you're not, if you're not doing it the way the NHS does it, you're doing it wrong. But it's a David and Goliath, isn't it? The Goliath is so big to conquer, but we will get there, definitely. Can you tell me about some joy in your clinic? Because just talking to you, I almost want to rush over there on an airplane and come and meet your clinic, because I can just picture the joy, the open, the warmth, and that reveal. Tell me about some of that, because I want to hear that joy.
Yeah. A typical week for us. So usually we'll operate on a Monday or Tuesday. I'm super lucky now because, like I said, it's me, my sister's the office manager, and we have like a wonderful staff. They're all handpicked people who are genuine allies, really care about this work. And so it's kind of, our office is too small not to have that, so our team, we're very cohesive, and basically we'll start on Monday, and usually patients are a little bit nervous, obviously completely understandable. So we'll bring them in, we'll get them ready for surgery, and then we'll go back and do surgery. On a typical day, we'll do like 3 or 4 surgeries. Usually they go to recovery, and then they head back to their hotel or wherever they're staying, because most of them fly in. And so then, I'll touch bases with them that night, and like that's kind of where it starts. They'll be like so relieved, so there'll be like so much gratitude at that point. Usually they're recovering there for like a day or two, and then typically Thursday is kind of a reveal day, so that's when they'll come back. And it's not unusual that they're traveling with like maybe parents, family members, partners, obviously, things like that. And patients traditionally in our because we're here in Miami, it's a subtropical climate, so patients have kind of, it's awesome, over the years kind of invented little traditions, so usually, for example, the transmasculine guys will come in their Hawaiian shirts, so they'll come in some sort of really ridiculous flamboyant shirt, very Miami Vice, so basically they'll come in, we'll remove the dressings from the nips, we'll get rid of the binder, and that's when they'll see their chest, for the first time. So it's very normal that there'll be tears, things will be documented, because it's like graduation. Like, this is like one thing they've looked forward to all their lives, and it's such a big deal. And they've chosen their outfits, their partners have chosen their outfits, we'll take pictures, and we go through all our instructions, and it's like such a happy emotional time, and you see all these dynamics playing out. I'm like gonna like tear up thinking about it, but like, with like, maybe the mom who's had a hard time accepting this, but now she's seeing her son, and she's seeing him comfortable in, his skin. And especially for trans mask surgeries, because it tends to be very euphoric to begin with, because honestly, for the most part, they look pretty good. There's some bruising and things like that, but they can see the shape, and they can see they've been working out their chest all these years, but now you can see pecs, so that's really the best day, so it's like Thursdays usually when we're doing that. And that's the part that the staff love, and everybody feeds off that energy. And yeah, like best day of the week, for sure.
That's lovely. That's so lovely. And what are you going to do when you get too busy?
Uh, so here's the thing. I'm a workaholic, I'm like, if this is why I need my sister to balance me, because she makes the schedule, so if it was up to me, I would work 6 days a week, but I would say, it's very controlled right now, because I mean, one of the things we deal with is access to care depends greatly on the economy. And certainly here in the United States, I feel like the economy is not doing great, so the practice will fluctuate a lot depending on that. So we're definitely trying to work more with insurance, as much as possible here in the United States, which is a whole other discussion. But, I don't think, if we get too busy, that's an amazing problem to have, and, we recruit. There's other surgeons who love to do this work, but, that, like I said, would be an amazing problem to have. But at the end of the day, unlike what media would have you believe, access to care is still extremely difficult, so, yeah, and patients, even if they're covered by insurance, there's a lot of expense, so.
I mean, yeah, I get it. And I mean, just closing up, I mean, the future for me for gender affirming care, if I had that magic wand, I think it would be, let's believe people when they say they're trans, because they ain't making it up. And puberty blockers save so much unwanted development. And then gender affirming hormones do a really good job, if you can get them in early to shape the body in a way that fits the gender. And then finally, it means that you won't get too busy, because we will prevent a lot of the surgery that you have to do to undo the damage that the wrong puberty did.
If we could just, treat this like other parts of medicine and surgery, and can we just look at the data and listen to the patients, and drop the other stuff, because we know the public in general, don't follow what leadership might be suggesting, like I alluded to earlier. So it's in absolutely nobody's interests, to bring in these damaging and, harmful policies, like the public in general, it certainly doesn't help them. And it certainly doesn't, help the patient. It's extremely harmful, to the patient as well. So it would be lovely if we could just focus on our work, and drop the other rhetoric. And also, one thing that's extremely frustrating is that the narrative out there, just the misinformation, like the amount of misinformation. It's kind of, we would be what people would have us believe, or sorry, for the media and certain politicians would have us believe, is there's massive amount of people regretting, their surgeries, and, that there's so much harm happening. But we're not seeing that in practice. None of us want to do harm. If that were the case, we would be, raising the alarm, obviously. But, it's just what we hear and what it's actually happening in reality is just, so different.
Yeah. Absolutely. I do agree with you. I don't think it's anywhere near as bad as it has been over the last couple of years. And we're seeing the tail end of it. We are going to survive this storm for sure. And then we can concentrate on medicine and surgery doing its job, doing what it's supposed to do. And I think as well, and I'm so grateful for you for being a loud and proud advocate and not shying away, not hiding behind doors, because people need knowledge. They need the proper information, not the misinformation. We need that. And we need the voices of experts like you and I to share our expertise. And we need the voices of the true experts, the transgender people themselves, to share their expertise and their lived experience, and put all that together. And we've got education, and we've got awareness, and we've got acceptance, and a society where trans people are deliciously welcomed instead of feared.
Yeah, and it helps everyone. It helps all the society,
Well, it's been absolutely fantastic talking to you today. So thank you so much for coming in and all the way from where you are. And I'm so grateful for your work and the people, the results that you've managed to achieve. Amazing. And keep up with that research and that training, just in case you get too busy.
Yeah, yeah. Well, thank you so much for having me. And, same to you. I really admire your advocacy, and, just keep using your voice. I mean, you're gifted with such an eloquent voice, and I just love what you're doing with it. So
thank you. Thanks for watching. Thanks for listening. And don't forget that I write about this all day, every day on my website. Come and have a visit. I'll see you there. Link is below.